Hi everyone, welcome back to the final part of the 2017 classification series. In this video, we are mainly going to focus on two broad sections. First, other conditions affecting the periodontium, and second, peri-implant health, diseases and conditions. Now, if you look at the classification carefully, this last part is actually very broad and heavily subclassified. And because of that, it often becomes confusing and difficult to relate clinically. So instead of trying to memorize everything together, let us understand it one step at a time. Now, according to the classification, other conditions affecting the periodontium are broadly divided into systemic diseases and conditions affecting the periodontal supporting tissues, acute periodontal conditions like periodontal abscesses and endo-periodontal lesions, mucogingival deformities and conditions, traumatic occlusal forces, and finally, prosthesis and tooth-related factors. Now, before moving ahead, let us first understand one very important area of confusion. Because if you remember from part 2, we already had a category called periodontitis as a manifestation of systemic diseases. And now again we have another category called systemic diseases and conditions affecting the periodontal supporting tissues. At first glance, both sound almost identical, but clinically they represent two completely different situations. In periodontitis as a manifestation of systemic diseases, the systemic disease itself predisposes the patient to true periodontal destruction and periodontitis. And if you look at the classification table, it mainly includes conditions like Papillon-Lefebvre syndrome, cyclic neutropenia, hypophosphatasia, and Ehlers-Danlos syndrome. But in this category, the condition itself is destroying or affecting the periodontal supporting tissues rather than initiating classic periodontitis. And if you look at the table carefully, this category mainly includes neoplasms and other disorders affecting periodontal tissues. For example, oral squamous cell carcinoma or Langerhans cell histiocytosis. Now, clinically, these lesions may initially resemble periodontal disease. A patient may present with localized bone destruction, tooth mobility, or soft tissue changes, but the underlying disease process is completely different. For example, Langerhans cell histiocytosis may produce severe localized bone destruction, sometimes giving the classic radiographic appearance of floating teeth. So the key difference is this. In the earlier category, the systemic disease predisposes the patient to true periodontitis, whereas here the disease process itself is directly destroying the periodontal supporting tissues and only mimicking the periodontal disease clinically. Now, another important category under this section is acute periodontal conditions, and this mainly includes periodontal abscesses and endo-periodontal lesions. Unlike routine periodontitis, these conditions are usually much more aggressive clinically and often present as dental emergencies requiring immediate intervention. Because here, the patient is not just complaining of bleeding gums or slow bone loss. The patient usually presents with pain, swelling, difficulty in chewing, suppuration, or sudden tooth mobility. Let us first understand periodontal abscess. Imagine a patient with chronic periodontitis who was relatively asymptomatic for months, and suddenly the patient reports a severe throbbing pain near one tooth associated with localized swelling and difficulty while chewing or biting. On examination, there is a swollen fluctuant gingival swelling, deep periodontal pocket, suppuration, and tenderness on probing. Now, clinically, this is no longer behaving like slow chronic periodontitis. The lesion has suddenly entered an acute destructive phase, and this is what we call periodontal abscess. A periodontal abscess is basically a localized accumulation of pus within the periodontal tissues. Now, if you look at the classification table, periodontal abscesses are broadly divided into abscesses in periodontitis patients and abscesses in non-periodontitis patients. In periodontitis patients, the abscess may develop during untreated disease, non-responsive disease, supportive periodontal therapy, or even after periodontal surgical procedures. Whereas in non-periodontitis patients, the cause are usually more localized. For example, foreign body infection, orthodontic factors, harmful habits, developmental grooves, root perforations, root fracture, or external root resorption. Now let us move to endo-periodontal lesions. These lesions are clinically important because they involve communication between the pulp, the periodontal tissues. And because both tissues are interconnected, infection can spread in either direction. Now imagine a patient presenting with deep isolated periodontal pocket, pain, suppuration, and sometimes even a sinus tract. But on vitality testing, the tooth responds negatively. So clinically, this is no longer behaving like routine periodontal disease alone. There is pulpal involvement as well. And this is what we call endo-periodontal lesion. Now, if you look at the classification table, endo-periodontal lesions are first divided into lesions with the root damage and lesions without root damage. Lesions with root damage include root fracture, root cracking, root perforation, and external root resorption. These usually carry a poorer prognosis because the structural integrity of the root itself is compromised. Lesions without root damage are further graded according to the extent of periodontal destruction. First, grade 1 is narrow deep pocket involving one surface. Grade 2 is wide deep pocket involving one surface. And grade 3 is deep periodontal pockets involving multiple surfaces. So unlike routine periodontitis, these lesions may originate from the pulp, the periodontium, or both simultaneously. And unless both components are identified and managed properly, the treatment outcome may fail completely. Now, apart from acute lesions, sometimes the problem is not infection, but the soft tissue anatomy itself. And this brings us to one of the most clinically important and slightly confusing sections of the classification, mucogingival deformities and conditions. Now, one major difference between the 1999 classification and 2017 classification is the inclusion of periodontal phenotype. Earlier, the focus was mainly on describing recession defects clinically, but the newer classification became much more biologically and surgically oriented because clinicians gradually realized that tissue behavior differs significantly from patient to patient. Some patient develops recession very easily, while other maintain relatively stable tissues despite inflammation or orthodontic treatment. And this difference is heavily influenced by the periodontal phenotype. Now, periodontal phenotype broadly includes gingival thickness, keratinized tissue width, bone morphotype, tooth form, and root prominence. So, it is not just about the gingiva alone. It represents the overall architecture and thickness of the supporting tissues. And this is exactly why it was included in the newer classification. Because today, periodontal phenotype directly influences recession risk, implant outcome, orthodontic stability, mucogingival surgery, and overall treatment predictability. Now, if you look at the older literature, you will commonly find the term periodontal biotype. And traditionally, three common biotypes were described. First, thin scalloped phenotype. These patients usually show thin, delicate gingiva, slender triangular crown, narrow keratinized tissue, and relatively thin underlying bone. Clinically, these tissues are much more prone to recession, dehiscence, and tissue breakdown. For example, a patient with thin phenotype undergoing aggressive orthodontic expansion may later develop gingival recession because the tissues cannot tolerate excessive buccal tooth movement. The second type is thick flat phenotype. These patients usually show thick fibrotic gingiva, broad keratinized tissue, flatter gingival contours, and thicker supporting bone. These tissues are generally more resistant to recession and tissue breakdown. And the third type is thick scalloped phenotype. Here, the tissues are thick, but the gingival architecture remains highly scalloped around the slender teeth. So clinically, this phenotype combines features of both thin and thick tissue patterns. Now, once we understand phenotype, the next major topic becomes much more easier to understand: gingival recession. Because recession is not simply gingiva moving apically, it is usually the result of multiple interacting factors. These include traumatic tooth brushing, thin periodontal phenotype, orthodontic tooth movement outside the alveolar housing, plaque-induced inflammation, frenal pull, aberrant tooth position, smoking, piercings, and lack of keratinized tissue. So, clinically, a recession is usually multifactorial rather than caused by one single factor. Now, one of the biggest changes introduced in the 2017 classification was the adoption of Cairo's recession classification. Earlier, we used Miller's classification. But Cairo's system is considered more biologically relevant because it is based mainly on interproximal attachment loss. Now, according to the Cairo's classification, recession defects are divided into RT1, RT2, and RT3. RT is recession type. RT1 recession shows gingival recession without interproximal attachment loss. So, clinically, the interdental papillae remain intact. These cases usually have the best prognosis for complete root coverage. RT2 recession shows interproximal attachment loss, but the interproximal attachment loss is less than or equal to the buccal attachment loss. Whereas RT3 recession shows interproximal attachment loss greater than the buccal attachment loss. These cases usually show loss of papillary support, black triangles, and much poorer root coverage predictability. Now, before moving ahead, let us quickly understand how this recession assessment table is actually filled clinically. Because this table is not simply classifying recession, it is helping us clinically document the phenotype, the severity of recession, and root surface characteristics together. Now, the first column is recession depth. This is measured from the cemento-enamel junction to the gingival margin. Then comes gingival thickness. This basically tells us whether the tissue is thin or thick. So clinically, this can be assessed using probe transparency, direct measurement, or imaging methods. The next part is keratinized tissue width. This is measured from the gingival margin to the mucogingival junction. And this becomes important because reduced keratinized tissue may influence plaque control and recession progression. Now the next part becomes very important clinically, CEJ assessment. Here, the table uses class A and class B. Class A means the CEJ is clinically detectable, whereas the class B means the CEJ is not clearly detectable. This commonly happens in cases with abrasion, erosion, non-carious cervical lesions, or restorations altering root anatomy. And finally, the table records the presence or absence of a cervical step. Step positive means a detectable root surface discrepancy or cervical step is present, whereas a step negative means the root surface remains relatively smooth without a detectable step. Now, apart from recession defect, the classification also includes several other mucogingival conditions which are very important clinically. The first is lack of keratinized gingiva. Now, clinically, patient with inadequate keratinized tissue often complains of discomfort during brushing, difficulty maintaining oral hygiene, and persistent inflammation around the gingival margin. For example, a patient may repeatedly accumulate plaque around mandibular incisors, not because they are careless, but because brushing itself becomes painful due to inadequate attached tissue. The next condition is a decreased vestibular depth. This is commonly seen in patients with high muscle attachment, post-surgical scarring, or thin mucosa. Clinically, a shallow vestibule makes plaque control difficult and increases tension on the marginal tissues during lip or cheek movement. Now, another important factor is aberrant frenum or muscle attachment. For example, a patient may present with midline recession, persistent plaque accumulation, or a pull on the gingival margin while moving the lip. And on examination, the frenum may be attached very closely to the gingival margin. In such situations, the abnormal frenum itself may contribute to recession and difficulty maintaining oral hygiene. Next comes gingival excess, and this category includes several different clinical situations like pseudo pockets. Here, the probing depth increases because of gingival enlargement without true attachment loss. So clinically, the pocket appears deep, but the attachment level remains unchanged. The second is inconsistent gingival margin. This is commonly seen in aesthetic areas where one gingival margin appears more coronal or apical compared to adjacent teeth. Even slight asymmetry may become very noticeable in patients with high smile lines. The next condition is excessive gingival display, or what patients commonly called gummy smile. Now, clinically, this may occur due to altered passive eruption, vertical maxillary axis, or altered lip dynamics. So, management depends on identifying the actual cause rather than simply removing the gingiva. And finally, gingival enlargement. This may occur due to plaque-induced inflammation, hormonal changes, systemic conditions, or certain medications. For example, patient taking phenytoin, cyclosporin, or calcium channel blockers may develop drug-induced gingival enlargement. The last category here is abnormal color. This mainly includes conditions like gingival hyperpigmentation or altered gingival coloration. For example, a patient may present with diffuse melanin pigmentation despite completely healthy periodontal tissues. So clinically, not every color variation necessarily indicates disease. Now, let us move to another very debated topic in periodontology, traumatic occlusal forces. For many years, there was a belief that excessive occlusal forces themselves could directly cause periodontitis. But one important change in the newer classification is that occlusal trauma is no longer considered a direct cause of periodontal pocket formation. In other words, plaque biofilm still remains the primary etiological factor of periodontitis. However, excessive occlusal forces can injure the periodontal attachment apparatus, especially when the periodontium is already compromised. Now, according to the classification, traumatic occlusal forces are broadly divided into primary occlusal trauma, secondary occlusal trauma, and orthodontic forces. Primary occlusal trauma occurs when excessive forces act on a tooth with normal periodontal support. For example, a patient receives a high restoration and later develops pain on biting, mobility, or fremitus, despite having normal bone support. Here, the force exceeds the adaptive capacity of an otherwise healthy periodontium. Secondary occlusal trauma occurs when the normal or excessive forces act on teeth with reduced periodontal support. For example, a tooth with severe bone loss due to periodontitis may become mobile even under normal chewing forces, because the reduced periodontium can no longer tolerate functional loading effectively. The third category is orthodontic forces. Now, according to current evidence, orthodontic tooth movement alone does not directly cause attachment loss, provided inflammation is controlled and periodontal health is maintained. However, excessive movement outside the alveolar housing, especially in the phenotype patients, may increase the risk of dehiscence, fenestration, and gingival recession. Now, clinically, patients with traumatic occlusal forces may present with mobility, wear facets, fremitus, pain during chewing, pathological tooth migration, or widened periodontal ligament space radiographically. So the important concept here is occlusal trauma may damage periodontal supporting tissues, but it does not independently initiate plaque-induced periodontitis. And finally, let us move to the last category under conditions affecting the periodontium: prosthesis-related and tooth-related factors. Now, if you look at this classification table, these factors are broadly divided into localized tooth-related factors and localized dental prosthesis-related factors. The first group includes tooth anatomical factors: root fracture, cervical root resorption, cemental tears, root proximity, and altered passive eruption. Now, clinically, all these conditions have one thing in common. They either favor plaque accumulation or make oral hygiene difficult or alter normal periodontal architecture. For example, root proximity may make plaque removal extremely difficult in interproximal areas. Similarly, developmental grooves or cervical enamel projections may act as plaque retentive areas, predisposing the site to localized periodontal destruction. Now, the second group includes prosthesis-related factors. This section mainly includes restoration margins placed within the supracrestal attached tissues, procedures related to indirect restorations, and hypersensitivity or toxicity reactions to dental materials. Now, one of the most important concepts here is biological width. or what the newer classification refers to as supracrestal tissue attachment. This basically refers to the soft tissue attachment present coronal to the alveolar crest, and it mainly includes junctional epithelium and supracrestal connective tissue attachment. Now, clinically, the body tries to maintain these dimensions very strictly. So, when restoration margins are placed too deep subgingivally and violates this attachment, the tissue reacts. Patients may develop persistent bleeding, chronic inflammation, gingival enlargement, discomfort during probing, attachment loss, or pocket formation around an otherwise well-restored tooth. For example, a patient may receive a crown restoration and later develop localized inflammation around that tooth despite maintaining relatively good oral hygiene. And on examination, the restoration margins may be extending too close to the alveolar crest. So in such situation, the problem may not simply be plaque accumulation. The restoration itself may be violating the supracrestal tissue attachment. Now let us move to the final major section of the 2017 classification, peri-implant diseases and conditions. And this was actually one of the biggest additions to the newer classification, because the older 1999 classification mainly focused on diseases around the natural teeth, while implant-related diseases were not comprehensively classified. But with the increased use of dental implants, it became essential to clearly define peri-implant health, peri-implant mucositis, peri-implantitis, and peri-implant soft and hard tissue deficiencies. One very important thing to understand here is that peri-implant tissues are biologically different from periodontal tissues around natural teeth. Unlike natural teeth, implants do not have periodontal ligament attachment. Instead, peri-implant tissues form through wound healing and osseointegration after implant placement. So, although peri-implant diseases may clinically resemble periodontal diseases, their tissue response and disease progression can behave differently. According to the workshop, two findings become extremely important in peri-implant diagnosis: bleeding on probing and radiographic bone loss. Bleeding on probing help distinguish healthy peri-implant tissues from peri-implant mucositis, whereas bone loss helps differentiate peri-implant mucositis from peri-implantitis. So, let us understand these conditions one by one. First, peri-implant health. Peri-implant health is characterized by absence of inflammation, absence of bleeding or suppuration on probing, stable probing depths, and no progressive bone loss. One important point mentioned in the workshop is that there is no specific probing depth that defines peri-implant health, because soft tissue thickness around implants can vary considerably. And peri-implant health may even exist around implants with reduced bone support, provided the tissue remains stable and non-inflamed. Next comes peri-implant mucositis. This is an inflammatory lesion limited to the peri-implant soft tissues without progressive supporting bone loss. Clinically, patient may present with bleeding on probing, redness, swelling, and increased probing depth due to tissue inflammation. But importantly, there is no radiographic bone loss beyond initial physiologic remodeling. And this distinction is critical because peri-implant mucositis is considered a reverse condition if plaque control is re-established early. But if inflammation progresses further with supporting bone loss, the condition becomes peri-implantitis. Peri-implantitis is a plaque-associated pathological condition characterized by peri-implant inflammation along with progressive supporting bone loss. Clinically, patient may present with bleeding on probing, suppuration, deep peri-implant pockets, mucosal recession, and radiographic bone loss. Unlike peri-implant mucositis, the inflammatory lesion here extends apically with actual destruction of supporting bone. The workshop also emphasized that peri-implant mucositis is considered the precursor of peri-implantitis, especially in patients with poor plaque control and irregular maintenance. Another important observation is that peri-implantitis may progress faster than periodontitis, often following a non-linear accelerating pattern. And if previous records are unavailable, peri-implantitis can be diagnosed with bleeding and or suppuration on probing depths of 6 mm or more, and bone loss 3 mm or more apical to the coronal part of the implant. The classification also includes peri-implant soft and hard tissue deficiencies. These deficiencies may result from periodontitis, trauma, thin phenotype, implant malposition, or lack of buccal bone. Clinically, these deficiencies may compromise implant aesthetics, phonetics, oral hygiene access, and long-term tissue stability. So, if you observe carefully, the 2017 classification integrates natural teeth, periodontal tissues, restorative factors, and implant biology into one comprehensive clinical framework. And with that, we complete the 2017 classification of periodontal and peri-implant diseases and conditions. In the next series, we are going to understand how periodontal diseases actually begins. We will cover dental plaque biofilm or host microbial interaction, gingival inflammations, histopathological stages of gingivitis, clinical changes in gingival tissues, the role of calculus, and how healthy gingiva gradually transitions towards periodontal disease. And trust me, this is not going to be a simple microbiology lecture, because once you truly understand how periodontal disease develops, everything else in periodontology start making much more sense. So if you enjoyed this series, make sure to like, share, and subscribe. And I'll see you in the next one.